Good evening, everyone. This is the 32nd webinar of FSIBC series. And today we have chosen a topic which is really very important. So local regional treatment of breast cancer includes a surgical oncologist and a radiation oncologist. And a close coordination between both of them is very important. To discuss today, we have our experts. So we'll start with the welcome address. I would like to invite Dr. Arun Goyal, sir, for the welcome address. Over to you, sir.
Thank you, Dr. Prekshi. It's my pleasure, as always, to welcome our faculty to the series of webinars that are going under the name of Focus Studies in Breast Cancer. And what I would say is that I am really, it's a heartwarming response that we have had. It's been nearly more than 3 years and it's going fairly strong. But I think the strength definitely depends upon our audience, and we are generally getting excellent audience response on a regular basis. So welcome all the faculty, all the audience, and I would like to sort of welcome my team members, including Dr. Prekshi, Dr. Rajiv Agarwal, Dr. Chirag, Dr. Safalta. As Dr. Prekshi mentioned, the topic basically is the field of radiation therapy. Overall, I would say is that our webinars have a little bit of a surgical bias in the sense that many of us are surgeons in the organizing team, but we try to sort of bring other aspects of breast cancer management and enlighten the surgeons in the best possible way. And so I think another thing which can be stressed is that when it comes to potentially curative treatment of breast cancer, the contribution of local regional therapy is still the sort of most important component. So together, surgeons and radiations achieve the maximum component of a potentially curative treatment. So what a surgeon should know in the era of multimodality management, while we deal only with surgery, we have to be aware of how the radiation oncologists are planning and how we can sort of cooperate to give the best to our patients. So with that objective, and as is our format, that we have a speaker who generally gives an overview of the topic, followed by a panel discussion where some more details are brought out. So I would hand over back to Dr. Prekshi and take it forward.
Thank you, sir. So we'll start with our first session. And we have with us Dr. Anushil Munshi. Sir is chairman and head of radiation oncology at Manipal Hospital. Over to you, sir.
Thanks, Prekshi, and thanks everyone for having invited me, and thanks to all the participants for joining us this evening. So can I share my screen now?
Yes, sir.
Priyanshi, please help.
Yes, sir.
Yeah, okay. So is my screen visible?
Yes, sir.
And I'm audible also, right?
Yeah.
Okay. So over the next 20 to 25 minutes, I would be trying to address to the best of my capability this kind of challenging topic where I'm supposed to speak what the breast surgeon would like to know about breast radiation therapy. So when I was thinking about this topic, I thought I could address it in two ways. So one, I could talk about some key facets of breast radiation therapy. And second, I could talk about some breast subsite within the breast area, local, regional, and everything, where modalities of radiation and surgery need to be integrated. Just to give you a quick snapshot before we move ahead, so indication for post-mastectomy radiotherapy for breast cancer in 2024, as we stand today, more than 5 centimeter tumor size, more than equal to 4 axillary lymph nodes, now more than equal to 1 with the later evidence. Locally advanced breast cancer, irrespective of the response that we get on neoadjuvant chemotherapy. Positive margins whenever they are there. or there is residual disease. And then there is emerging evidence for triple negative stage 1 and stage 2, including post-MRM. So this is still an evolving area. I'm not saying it's a standard of care, but it's an evolving area in post-mastectomy triple negative stage 1 and stage 2. So what are the indications for RT post-breast conservation in 2024? I would say all cases, and I would be talking about a bit of exception towards the end, and preferably also give a boost as well. Now, before starting radiation therapy, and this obviously the resident surgeons or the junior surgeons that are there and that are hearing this, probably this would be of some interest to them. So we usually keep a gap of around 4 weeks from the date of surgery in patients who require immediate post-op radiotherapy, and a gap of around 2 to 3 weeks from the last chemotherapy in patients who receive chemotherapy after surgery. Skin needs to be completely healed. There should be no unhealed area in the skin. And I always request everyone, and surgeons are always anyways prompt in starting post-operative exercise. What I keep on telling patients is that it is also important, not only from their arm mobility point of view, but it is also important from the radiation point of view, that their arms are mobile, they are doing arm exercise, so that abduction that is required at the time of radiation for positioning, we always do, the arm has to go up and it has to be abducted. So if exercises have not been done, then it becomes a challenge for us. So that is one thing I would stress, that all of us, whether they are surgeons or radiation oncologists, need to emphasize after surgery. Careful decision has to be taken if seroma is present, because it's a bit of a dilemma, because if you aspirate seroma just before radiation, it may fill again during the course of radiation and it may disturb the planning. However, so that is one reason why you should not just as a reflex aspirate seroma before radiation, aspirate any seroma before radiation. But if there is a tense seroma which is causing discomfort, it may still need to be addressed. But then you have to be careful during the course of radiation by imaging and all that it doesn't start filling again. And if it does, you need to keep on checking and restoring it back to the position in which you have done the simulation, or you do repeat simulation. So these are some points that need to be considered. In breast cancer radiation therapy, we have evolved from standard fractionation, which used to be a long 5-week schedule. And I would say it used to stretch up to 6 to 6.5 weeks in patients who had breast conservation, because if you added the boost, then it would become around 6 to 6.5 weeks. But we know that we have got strong evidence for hypofractionation now, and we can finish the entire treatment in 3 weeks' time. In fact, we can integrate the boost as well in 3 weeks and finish the entire treatment after breast conservation in 3 weeks. And this can be extrapolated to post-mastectomy patients as well. So that's a big gain from 6 weeks down to 3 weeks. Then we are also in a select group of patients giving extreme hypofractionation, where we just give 5 fractions and finish the entire treatment in 1 week, especially in patients with small tumors post-breast conservation. What is the evidence that I'll just give you a snapshot of evidence. I'll not go into each and every trial. I'll just give you a snapshot of evidence that surrounds hypofractionated radiotherapy. So it has come for early invasive breast cancer. It has come for total mastectomy, and some bit of evidence is there for DCIS. And this is the list of trials, which you can see on the left side. And the way they have scheduled, the dots represent one fraction. The dots represent one fraction. And this is the way they schedule their fractionation in terms of weeks: week 1, week 2, week 3, week 4, week 5. And as you can see, some have just ended on week 3, such as the START B, which has become a reference point for most radiation therapy post-RT cases. 40 grain 15 fraction comes from START B. And then at the bottom of the slide, you will see the emerging and talked about is the fast forward trial, where you just finish the entire treatment in 1 week, giving 5 fractions. In all these trials, you can see the patient characteristics. A lot of patients were PT1, T2, around 25 to 30% had node positivity, around 30%, 25 to 30% received chemotherapy, and boost varied from 30% to 60%. in these cases, and regional nodal irradiation, around 15 to 20% patients received regional irradiation. Outcomes were quite satisfactory. They compared these hypofractionated arms with the standard fractionation, and they found very, very comparable outcomes, very impressive outcomes. So that is how these became the standard of care. As far as toxicities are concerned, they actually found that hypofractionated 3-week schedules were softer in terms of toxicities. That means they were having lesser toxicities. As you can see here, this is a START-B trial, the third in the list on the top, the START-B trial. And as you go down, on the right-hand side, you have the 40 gray, the arm, and on the left side, you have the 50 gray arm. And you can see consistently on the right side, you have lesser number of side effects, lesser toxicities, lesser telangiectasias, lesser breast shrinkage, lesser arm edema, and so on and so forth. Now, shifting gears a bit and talking about regional radiotherapy. Now, this is also a very, very interesting domain, and this continues to evolve, and there are many nuances and facets that have come in regional radiotherapy. In fact, regional treatment of breast cancer has become quite evolved of late. So as far as regional radiotherapy is concerned, it could be just SCF, it could be IMC, it could be a combination of SCF, IMC, it could be SCF plus Exila or SCF plus IMC plus Exila. So depending on the situation in the given context. This is an important article which I came across a few months ago. It was published in Lancet 2023, the Lucent Toolbox 2, meant to optimize axillative management for early breast cancer. It was a multidisciplinary expert consensus, and it was an integrated approach from surgical oncology and radiation oncology, because we need to balance the risk of lymphedema versus the risk of disease. And we know that the management is complicated by the use of neoadjuvant systemic therapy, and varied molecular subtypes pose additional challenge. So in a nutshell, I'm not going into the details of what they told in this article, but it was a consensus, and this was the nutshell. So they divided it into upfront surgery scenario and post-NACT scenario. And as you can see, they have tried to put forward, I'm not going into detail for each and every scenario, but what they have tried to put in is every possible scenario. For example, you did upfront surgery, you began with a CN0 patient, did sentinel lymph node, and found a PN+. What is the approach that you should do for such a patient? You found it PN0. What should be? Like, for example, PN0, you don't require to do any further local treatment. So similarly, for a CN1, what should be the approach for an upfront? Obviously, if you have more than that, you will go for some form of neoadjuvant therapy. So in a post-NACT scenario, if you began with a CN0 or a CN1 patient, gave primary systemic therapy, and then you reached a stage where it was YCN0 or YCN1, and then it was actually PN+, or as you can see in the middle row, or PN0. So what are the options for surgery? And if you do that surgery, what should be the corresponding radiation? So I think this is a very, very important chart in the present era that leads us to some kind of a way out in different scenarios that we are facing these days. So these are all the possible permutations and combination. Broadly speaking, for the radiation oncologist, it is important to know that we should focus on the portion of the axilla that is not been dissected, unless we are in a very high-risk situation where there is some residual disease left, or very, very heavy nodal burden and perinodal extension and things which are once-a-while things. The routine should be to avoid overlapping your radiation field with what has been dissected out. And of course, they considered some additional risk factors also in these cases. For example, if you have these kinds of scenarios that as mentioned above, but if you have risk factors such as non-luminal A, grade 3, middle, high, genomic risk, LVI, then obviously you need to give some consideration for these things as well. I again switch gears. I'm moving quite fast and switching gears because I thought I could cover a few more things in the allotted time. So APBI is one more thing which I thought I should cover. And in APBI, we have various recommendations, including ASTRO, ABS, Jekestro, ASPS. So broadly speaking, most of the guidelines say patients should be more than 50 years, tumor size less than equal to 3 centimeters, preferably node negative, IDC patients margin negative, ER positive, LVSI negative, and no neoadjuvant chemo. And there are various techniques that we have, including interstitial, which you can see in the lower right side, 2 panels. So paraoperative brachytherapy, Mammocyte, Mammosphere, Target, Eliot, and so on and so forth. There is more than 95% local control rate at 5 years with most techniques of APBI. And these are the trials. And I have tried to again recapitulate the most important trials, including the APBI IMRT Florence trial, which has become the preferred external beam APBI way now, which is 30 grain 5 fraction, 1 fraction alternate day. So this has become the preferred modality for giving external APBI. And then you have brachytherapy techniques which are substantiated by, for example, the NSABP B39 or the Jekestro trials. And of course, there have been some approaches such as the rapid trial approach, which have been kind of shown some bit of negative results of 38.5 grain 10 fraction and shown poor cosmetic outcomes. So that is why the first in the topmost is actually the one that is preferred for external, and for brachytherapy, it is the bottommost, the Jekestro approach that is to be preferred. Talking about boost. Now, this is another important thing in breast radiotherapy. I would say boost should be given in all breast cancer patient post-breast conservation, but especially patients who are young, patients who have high-grade tumors, patients who are triple negative, patients who have residual tumor after neoadjuvant chemotherapy, and patients who have margin positive, where you should probably give an extra dose as well. And this is the age effect, where it is shown that patients less than 40 years, perhaps younger patients, which probably benefit the most, but obviously you have to consider other factors as well. Now, of interest to these surgeons is oncoplasty. And there are issues, and it's talked about in several conferences. It's a hot topic of debate, that post-oncoplasty boost, what should we do? Surgeons do this, that, and all that stuff. But then it is a reality, and we have to accept it. So there will be parenchymal rearrangement, which is inherent to oncoplasty. There will be tumor bed, which is located at some distance from the skin incision, or which will be relocated out of the original tumor quadrant in a significant percentage of cases, especially if you have advanced oncoplasties. So original tumor location, scar, seroma cavity, they are not reliable guides for local boost radiotherapy in these situations. And I would say sometimes this can affect not only the boost, the oncoplasty can not only affect the boost, it can affect whole breast radiotherapy planning as well. So these are the different, I know it's a very learned audience, so they don't need to be told, but just generally speaking, there are various scenarios where you have oncoplasty rearrangement, several types of rearrangements. So bottom line is that we need to have the radiation oncologists and the surgeons on the same page. And it's especially important in patients who require boost, because we know that higher boost volume, if we increase the boost volume, we're likely to impact overall cosmetic outcomes. Now, as far as boost delineation issues are concerned, and this comes from the latest import trial, which came from UK, and they recommend that clipping should be done using paired 6 mm titanium clips around the tumor bed. Now, obviously, if you don't have titanium clips, you use the regular clips. So medial, lateral, superior, inferior, halfway between the skin and the fascia. Deep is midpoint, usually at the pectoral fascia, the posterior, and anterior is close to the suture line, avoiding the skin. This is what the import trial recommends in terms of delineation. And obviously, we know, and this table at the bottom tells us that there could be volume displacement processes, which is level 1 which could be further categorized into level 1, where due to less than 20% breast excised volume is there, and level 2, where the 20 to 50% excised volume is there. And then you have volume replacement procedure. So these things one needs to be keeping in mind. And obviously, there could be challenges in boost delineation. For example, this figure that you can see here. So if you have transposed some tissue here, which you can see in the center, would that be actually at risk of recurrence? Probably the interface of the normal tissue and this new thing that you have, the cavity surrounding it. So probably a ring-shaped kind of a boost area would be at risk. However, these things have not really been dissected out threshold. So if someone would say, no, I will just take the outer volume, I mean, just include the entire thing within my volume, I wouldn't say that he's completely wrong, but it would be difficult to justify that the inner area, which is the tissue that you have brought from somewhere, the inner and the innermost area is actually going to have recurrence. But again, these things have to be discussed with the surgeon when the radiation oncologist is planning. And it's not a bad idea to call the surgeon to the TPS while you're delineating the boost, especially so as you're sure that whatever displacement he has done of the original tumor bed area is actually being covered in the boost volume. Now, post-mastectomy scenarios, you have types of implants, you have breast implants, or you have autologous kind of reconstructions where you have tram, latissimus dorsi, gluteal flaps, and so on. But in breast implants, again, you could have situations where you have a subpectoral implant where you have gone beyond, you've taken portion gone beyond the pectoralis, or you can put it anterior to pectoralis. So it depends on your approach, but obviously more and more people are trying to go behind the pectoralis so as to give a cushion and probably decrease the chance of gaping and other complications, especially when you're going to give radiation therapy. Again, there can be several approaches for reconstructions or implants. Immediate autologous. Now, there is increasing favor for this approach now, and because post-mastectomy radiotherapy with this approach appear to be under control. Then there could be direct to implant reconstruction where you directly go in for the implant, which can actually sometimes have side effects, a higher chance of side effects with PMRT. And then you could go for immediate two-stage prosthetic reconstruction where you put an expander and then remove the expander and put the implant. But then again, whether you should irradiate while the expander is there or it has been replaced by the implant is again a slight, exact timing is slightly controversial. And then you could consider something, there is another option of delayed reconstruction with implant, but then it has a higher risk of post-RT complications. So these are the different approaches that one can take and pros and cons of each. Recently in 2022, we had this interesting approach from the PRADA investigators. It's a small trial, but what they did was interesting because patients who started chemotherapy, as you can show in the flow chart, they completed the chemotherapy. And instead of surgery, they took preoperative radiotherapy. They took preoperative radiotherapy and then underwent skin sparing mastectomy and DIP flap reconstruction, and then were subjected to follow-up. Endpoint was gape more than 1 centimeter. At 4 weeks, only 10 or 12% had a wound greater than 1 centimeter, which seemed quite satisfactory. There were no serious side effects. So this is one more approach that can be tried, and there would be increasing evidence of this as well. The pre-operative radiation part followed by reconstruction. I would like to caution my radiation oncologist colleagues and juniors here that please avoid ultrafractionation, which is less than 5 fraction schedules in patients with reconstructions, with significant oncoplasties, and with implants. The evidence for using 5 fraction in these schedules outside the clinical trials is actually very, very minuscule. So please avoid, and there have been some reports of some toxicities as well. Now, another hot topic that is the flavor of the season at many meetings is avoiding radiation therapy after breast conservation. So can it be just avoided? And we have some evidence from the CALGB, PRIME, Lumina trials. And what they told us is that more than 70 years, patients, T1 patients, or very early T2 patients, N0, luminal A patients, this approach has been tested in such patients in these trials. So they have found that local recurrences were slightly but significantly, statistically significantly higher, but overall survival remained the same. So this approach, if anyone wants to consider, please tell this to your patients. They have to accept higher risk of local recurrence with this approach. They have to accept side effects of hormonal therapy with this approach. And side effects of hormonal therapy can be there. We all know, because hormonal therapies are not toffees. And patients should be fully compliant for hormonal therapy, because it is also well known that around in general population of patients, around only 50 to 60% complete their 5 years of hormonal therapy. And if you are subjecting patients to this kind of approach where you're avoiding radiation, and those patients who are not taking hormonal therapy also, they have a 4-fold higher chance of local recurrences. So please keep these things in mind while you're subjecting your patients to this kind of an approach. This is the snapshot of the Lumina trial. And of course, biomarker-based breast RT de-escalation is also being tried, both for breast as well as for tailoring regional radiation. I'll move to some snapshot where these are kind of fast bites. So we had some provocative data around a year ago, Querer et al., where I talked about recently about RT de-escalation. So there has been talk about breast surgery de-escalation also. And in the trial by Querer, he took patients. It was a small group. I think they had around 30 or 35 patients. But they took patients, and after neoadjuvant chemotherapy, they took biopsies, multiple biopsies. And if they did not find any invasive or in situ disease, these patients underwent standard radiation, and they were just followed up. And for this small subgroup of patients, at a median follow-up of 26 months, no ipsilateral breast tumor recurrences occurred in these 31 patients. So this is a very important, although small, but provocative data that is coming up. Another question in the mind of both surgeons and radiation oncologists is, okay, suppose we have more than one lesion, can breast conservation be done? And data comes from the ECOSOG Z1102 Alliance trial that if you have selected T1, T2 patients, node negative population, and only not more than 2, just 2, because 95% in this trial had just 2, and more than 50 years of age patients, node negative kind of population. So you could do breast conservation in such patients as well. But remember the selection criteria. And 5-year cumulative incidence of local recurrence was around 3%. So that is again quite acceptable and encouraging in this group of patients. And of course, they received radiation. From the radiation oncologist point of view, both the sites have to be given boost, and they were given boost. But again, long-term data about cost measures and outcome is a bit awaited. I've already talked about seroma and collection issues. So generally avoid drains, because most of these seromas settle on their own. But sometimes you are in a desperate situation where patient is very uncomfortable, or just the seroma is too much. So even if you have to put a drain, make the entry point much behind the posterior axillary line, so that when the radiation is given, the drain site is away from the portal. So that helps a bit. Another thing that is forgotten these days is radiation ovarian ablation. So as you know, ovarian ablation or suppression can be direct, which is done by surgery, radiation, LHRH agonist, or it can be indirect, which is chemotherapy induced. But somehow, for the past few years, it's just LHRH agonist and occasionally oophorectomy that we kind of hear. But as I can show you in this meta-analysis, which had 6 trials, the amenorrhea rate is excellent, very superb rates of amenorrhea with RT ovarian ablation. Provided you do a good job, you have to do CT, you have to delineate the ovaries and then fire the ovaries. So in just 4 sittings or so, you can knock off the ovaries and ablate them. Another question often in our minds is whether we can give concurrent hormonal therapy and radiation therapy, and we have proven in our, and I actually at Tata Memorial Hospital, I started this trial as the principal investigator, and it was presented in ASTRO last year in the plenary session, where we have demonstrated in a randomized trial that there is no difference in pulmonary toxicity or any other endpoint so far, that if you give concurrent radiotherapy and tamoxifen, there is any higher chance of side effects. So obviously, I mean, it's a randomized data. There is no reason now to withhold tamoxifen during the course of radiation. And of course, we have data from aromatase inhibitors also in a randomized setting that they also can be given freely along with radiation concurrently. And then in special situations, we have some bit of talk about oligometastasis and local treatment. So we are all aware of the slightly disheartening results that we had from NRG-BR002, where we had standard of care treatment versus stereotactic body radiotherapy or surgical ablation for newly oligometastatic breast cancer. We know that this trial did not give us very encouraging results of treating the oligometastatic site with ASP, RT, or some kind of surgical removal. However, there are some criticisms of this trial. It was just meant for ERPR positive patients. It was for a select group of patients. So people have been asking that whether we can extrapolate the same principles to HER2 and triple negative populations. Other thing is that the median follow-up of this trial was a bit limited, and we have got other trials in other oligometastatic sites, primary sites, where they have shown benefit after 4 to 5 years. So these things need to be sorted out before we actually dump treatment of oligometastatic breast cancer and say that it doesn't help. So the other question that we have, especially from the surgical point of view, is that surgery, local surgery, needed in metastatic breast cancer? So instead of going into each and every trial, I present to you this pooled analysis that compared systemic therapy on one hand and systemic therapy added along with local surgery in the other arms. And it was shown that breast surgery was not associated with beneficial outcomes in terms of overall survival, distant progression-free survival, QOL, and so on and so forth. It was only associated with a benefit in local recurrence rate or local progression-free survival. That was the only benefit that comes from local surgery. So this is what the evidence is there so far. But obviously, in an individual patients, we can go to the multidisciplinary clinic and discuss for an individual patients. So that brings me to the take-home messages. This is the first slide of take-home messages. And I thought of putting before you the consensus statements, which were recently published in Lancet Oncology from the European Society of Radiotherapy and Oncology Advisory Committee. So for whole breast radiation, moderate hypofractionation, which means a 15 fraction schedule, good enough, can be used in most situations and can be used for nodal radiation as well. Ultra hypofractionated, where you are using just 5 fractions, can be used for a specific group of patients, and preferably a group of patients where you do not actually need regional radiation because data for that is still limited. For chest wall radiation, again, moderate hypofractionation, we have a randomized trial, so 15 fraction schedule can be used. Moderate fractionation can also be used for chest wall radiation, regardless of time and type of breast reconstruction. So again, moderate hypofractionation, but not ultra hypofractionation with breast reconstruction. So please avoid ultra fractionation. For nodal radiation, moderate hypofractionation, 15 fraction, as I told, ultra hypofractionation for nodal should be avoided. Partial breast irradiation, I have already discussed the criteria and the dose and the fractionation. So surgical oncologists and radiation oncologists need to provide integrated approach to patients for local regional management. Multidisciplinary tumor boards are a must before patient starts treatment. All breast conservation cases need post-op radiation therapy. And of course, PMRT is of critical importance in indicated patients. Modern radiation is much safe and has got a very safe side effect profile. I repeat that hypofractionated RT should be offered to most breast cancer patients. It's cost effective, it is time effective, it is logistically effective, but use extreme hypofractionation and APBI only in select group of patients and be cognizant of the emerging indications of breast RT and post-mastectomy radiotherapy. With these words, thank you all very much for your patient hearing.
Thank you, sir. That was a great comprehensive coverage of the topic. And I would request you to please stay, if it is feasible for you, for the panel discussion also.
Sure.
Next, we will have a panel discussion, which will be moderated by me and Dr. Chirag. Next, please. So, I'll invite the panelists. Dr. S. Jayalakshmi, ma'am is senior consultant in radiation oncology at Artemis Hospital. Dr. Swarupa Mitra, ma'am is director radiation oncology, Fortis Hospital, Gurgaon. Dr. Indu Bansal, director and head radiation oncology, Paras Hospital, Gurgaon. And Dr. Anushri Vartak, she is a senior consultant in surgical oncology, Yeshwada Hospital, Ghaziabad. So Dr. Chirag will start over.
Thank you, Dr. Prikshi. Am I audible?
Yes, yes, you are.
Yeah. Thank you, Dr. Prikshi. So indeed, a very comprehensive and an enlightening talk by Dr. Anushil sir. And as a surgeon, it's very difficult to stay glued to a talk, but yes, a very interesting talk on radiation oncology. Few doubts in my mind got cleared and maybe few new doubts, which I would try to incorporate into the panel. And welcome to all the panelists and all the audience. So let's begin with the panel discussion.
Just a second.
Yeah.
Is it visible?
Yes. So, next, please. Next. So my first question would be to Dr. Anushri, as a surgical oncologist. First thing that I would like to know from her is, as a surgical oncologist, at what point in your treatment do you usually involve the radiation oncologist in a breast cancer patient who you believe would be, needing radiation?
Yeah, excellent talk by Dr. Anushil, and thank you for the invitation. I agree with Dr. Anushil that ideally, yes, in all patients, right from the beginning, it needs to be a multidisciplinary treatment, and all the concerned specialists should be involved. But especially in high-risk patients where we know that, especially in breast conservation, when we know that there is an indication for boost, or we are planning a complex oncoplastic procedure. So there, I would involve the radiation oncologist right from the analysis of preoperative imaging in that phase itself. Another important area is when we are going to do mastectomy and there is whole breast reconstruction plan. And if that patient has a potential for PMRT, then again, that is an important area where the radiation oncologist should be on board. And generally speaking, I think MDT culture needs to be there, and we need to be on the same page with so many things. Like, for example, all these axillary treatment trials, not all patients had axillary ultrasound as staging, right? So as a team, we need to agree about, we need to be on the same page about what our axillary staging investigations are going to be, or there are some controversies like intermediate risk patients, or as Dr. Anushil said, that there should not be any overlap between the surgical and radiation treatment of axilla. So these are the areas I think that you need to have clarification from your radiation oncology colleague.
To Dr. Jayalakshmi ma'am, so ma'am, how soon would you like to be involved in a breast cancer surgery patient, and how does it help you in your planning?
You are muted, Dr. Jayalakshmi.
Yeah, so if it is particularly very small tumors, I would like to be involved right from day one, because, you know, if there is a possibility for like along with the surgery, whether we can go ahead with an interstitial implant, these things needs to be sorted out. But that is the earliest, particularly in smaller tumors. But otherwise, most of the time, the reality is that we come in when, you know, probably the surgery has been done and we have the histopathology reports, and that is when we are coming in.
Thank you. Dr. Sarupa ma'am, so is a pre-op CT scan helpful in treatment position in the later planning of the radiation therapy of the patient? A pre-op CT scan, does it usually help?
Yeah, before I, thank you so much for inviting me, Dr. Prekshi and Dr. Chirag and Dr. Vaishali. Before I come to this question, I would like to add a little bit on the previous question. It is, we would also like to see the tumor for the breast conserving surgery, but it is very important. Many times we do not have any idea of the skin involvement. How much was the skin involved initially? Whether the nipple was involved or not, whether there was any edema or not, because after surgery, neither the PET scan shows this, nor any clinical notes show this. So it will be very important not to, that we be involved initially, not only for the tumor as a breast conserving surgery boost, but also for the skin involvement and the nipple involvement. The next is pre-op CT scan in treatment position. I probably, you know, I never thought of this, but maybe, you know, pre-op CT scan, I do not know how much is going to help, because if it is a breast conserving surgery done or a mastectomy done, the anatomy changes. So the treatment position exactly, especially for breast, maybe it helps in Hodgkin's in lymphomas, but in PET-CT, I'm not very sure how much it is going to add to our treatment. But yes, if the PET-CT can be done in the treatment position, which many hospitals, many scan centers are doing, so that may be a great lot of help to find out the initial tumor volume and the site of the tumor.
So, and how can the surgeon contribute in the radiation planning? Your thoughts?
Yeah, yes. So the surgeons can definitely, because like I said, it has to be, like we said, that it has to be a multidisciplinary team. The first time when the radiation oncologist is involved, it is not only the radiation oncologist, the surgeon as well. So to mark because after the breast conserving surgery is done, so the surgeons, we can discuss that, you know, where the clips need to be placed. Where is the exact site of the tumor? The site of the clip, not only for the breast conserving surgery, the breast tumor bed, but also for the axilla. So these are very important. The surgeons can help us, and we can do together in marking the tumor cavity and also the lymph node area, especially if there are some large nodes.
So Dr. Anushri, so how often are you involved in the radiation planning, or how often does your radiation oncologist call you to the planning room to discuss the plan?
The surgeon.
Yeah, Dr. Anushri.
So when we are doing
Acha, sorry.
complex, when we are doing complex oncoplastic procedures where we are going to, there's going to be a lot of volume displacement. So at that time, I usually discuss the tumor location, what I'm exactly going to do in the surgery, how the tissue is going to shift. And sometimes when we treat these multiple primaries, that is also an important time where from the beginning we discuss whether how much cavity can be boosted, or if there are multi-centric tumors, then is it feasible to boost cavities. And during the treatment planning, if in such complex cases, I mean, if there is any doubt in the mind of radiation oncologists about what has been done, then they ask for some clarification.
Right. So next, please. So Dr. Indu wants to know.
Dr.
Yes,
Chirag, can I
Yes,
just chip in a bit?
Sure.
I think it was this issue of CT scan done prior to surgery. So maybe I just wanted input from Dr. Anushil and Dr. Indu also, because I have seen some radiation oncologists who say that doing a preoperative CT scan in a treatment position has been very useful and they vouch for it. So whether Dr. Anushil has any experience or any opinion about this, Dr. Indu
I think
also
Anushil sir has left.
has left.
Dr. Indu wants to know. Yes.
Okay.
So Dr. Indu wants to know.
Yeah, good evening, everyone, and thank you so much for having me here. And there was this excellent talk by Dr. Anushil. Few points that I want to make here. Number one, to my mind, radiation oncologist and the surgical oncologist both have to be involved right from the beginning. I mean, if a patient comes to a radiation oncologist, it's my prime responsibility to show to a surgeon right away before the patient goes for any chemotherapy. Similarly, if a patient goes to a surgeon, the patient should be seen by a radiation oncologist for many reasons. Number one, these days in the era of immunotherapy and neoadjuvant chemotherapy, many a times the tumor just disappears after chemotherapy. And if you're planning to get a breast conservation surgery done, then I have seen sometimes breast conservation being denied because the tumor has disappeared and the surgeon says we don't know what to operate. So as a radiation oncologist, then it becomes very difficult for us and a patient loses her breast. So we usually offer to get a marker placement or a clip being placed before neoadjuvant chemotherapy. So for patients for locally advanced cases as well as for early breast cancers, if a radiation oncologist has seen the location of the tumor pre-treatment, pre-chemotherapy, pre-surgery, it definitely helps us in better radiation planning. Number two, like as you said, that when a patient has underwent an oncoplasty, even after that, if we have seen the tumor before, and as Dr. Sarupa also mentioned, we need to understand, was there any nipple retraction? Was there any preoperative edema present pre-chemotherapy? So these days, in the era of immunotherapy, also we are seeing complete disappearance of tumors pre-surgery. So as a radiation oncologist, if we are involved right from day one of the diagnosis, it definitely makes a difference. It also helps in decision making. Like sometimes we have seen patients coming to us after a breast conservation and radiation has not been discussed with them. And then they get surprised, oh, I have to get radiation also. And then they're in a state of shock. So if we tell them beforehand that if you're going for a breast conservation, then radiation is a must. So the patient is mentally prepared and patients get the required treatment. So these are my inputs. And of course, we invite our surgical oncologists many a times in the TPS, specifically after oncoplastic surgeries in a bulky breast. And one more issue that comes up is that if the surgeon also comes in the treatment planning, they must understand that we have to include the scar. And many a times, the lateral most end of the scar is quite beyond the mid-axillary line. And because of that, we have to include a lot of extra area in our radiation planning. And also the drain site sometimes is completely out of our radiation field. And then you see some drain site recurrences. So I think the surgeon must know how we plan a radiation case. And as a radiation oncologist, we must know what a surgeon is going to do in the OT. So it has to be a teamwork, and I really want to emphasize again and again that a radiation oncologist has to be involved in all the cases, whether it's a early disease, whether it's a locally advanced disease. Now, point number 2, this issue regarding pre-op CT scan and treatment position. So I think it has some advantages, but it has some disadvantages also. The advantage is that when we have to do a boost planning, and it's not a reconstructed breast, it's a complete normal surgery, then definitely knowing the pre-op position helps us in boost planning. But sometimes I doubt that even if we do a pre-op CT scan and treatment position, it would be replicable post-surgery because of fibrosis. The patients have pain, and we are not able to put them in exact same position in which the pre-op CT scan was done. So there would still be some displacement. I have not tried that in many cases, but it might be of help, but I'm not sure that I would say that it should be recommended as a standard procedure as of now. So many a times, even at good centers, surgical clips are not placed, which makes it's very difficult for us to plan the boost. So I would urge all my surgeons to please start putting clips in conservative breast as well as in conservative breast where we have to plan a boost. So these are my few cents, but I think there's no harm in having a coffee together before sending the patient for chemotherapy.
Right, ma'am. Very interesting point. So, Dr. Anushri, just taking it forward, Dr. Indu Bansal was pointing out especially there are few patients who are not really well counseled about, the absolute need for radiotherapy post breast conservation. So, how do you go about your discussion with your patient regarding decisions for breast conservation and mastectomy? And in your practice, does it really change the patient decision making, the need for radiotherapy post surgery?
Yeah, I agree with Indu ma'am that it has to be a sort of joint counseling from the beginning, and not just about radiation. Breast conservation rates and their acceptance is still an issue in India, and sometimes we know that patients are counseled that in early breast cancer, if we do a mastectomy, then they'll be spared of RT, but it's not really based on evidence. We know that breast conservation therapy has superiority over mastectomy in early breast cancer. So I think that if counseled jointly by the surgical and radiation oncologist, that this is I mean in the early breast cancer patients, that this treatment has superiority, it helps in patient choosing for breast conservation and not see radiation as something optional or which needs to be avoided. The other thing is that the breast conservation and oncoplasty, all these are evolving things, and we need to work together to increase their acceptance rate. So breast surgery is now, I think, completely synonymous with oncoplastic breast surgery. The days of conventional breast BCT or leaving seroma are gone.
Thank you.
Dr. Chirag, I would like to add here that many times the patient think that if she undergoes mastectomy, then she would be spared from radiation.
Exactly.
So that is, and that is a paper, I think,
That's
10 years back by Jagsi et al. And they did a survey, and many times it happens. So if the patient or the attendants, they meet the radiation oncologist and they get to understand that even if it is mastectomy, then there might be chances of converting that mastectomy into breast conservation therapy.
And I think one more point, sorry for taking the time, but I would like to add here that sometimes when a surgeon counsels the patient that you will need radiation, so patient thinks that radiation is going to be a very bad thing, that if I take, oh my God, I'll also have to get a radiation, which will add to a lot of toxicity. But these days with our advanced treatments, even our cardiac toxicity and pulmonary toxicity are to the tune of 2 to 3% only. So the radiation, like your surgical techniques have evolved a lot, so have our radiation techniques. And now the toxicity is is very minimal. Even the skin reactions, they are grade 1, grade 2, and we are taking care of lymphedema and all those things also. So the radiation toxicity is not that bad, which the patient presumes it to be if they have not met a radiation oncologist. So that is why many patients end up having a mastectomy and they have to live. Every patient in India cannot afford a reconstruction post MRM. So please, we have to keep this in mind that losing a breast is for the lifetime, but getting radiation will be hardly for 15 days. 3 minutes treatment, 5 minutes treatment, 15 days treatment. It's an OPD procedure. So we have to be convinced ourselves first that radiation plus breast conservation results are equivalent to mastectomy, and some patients post mastectomy might also need radiation. So I think we have to choose our patients well and counsel them well.
May I also add here that, like Indu said, when we are talking about toxicities, we are talking about the clinical toxicities here. There is a fear about radiation also among most of the patients because it is a treatment which many have not probably seen in any of their families. They might have seen some form of surgery done for something or the other. So visit with the radiation oncologist is going to actually take them out of this and get them to understand that most of the breast-related radiotherapy, I mean, of course, it is from outpatient basis. There are so many who actually do the work, come and take the treatment and go. So once they understand this part, many of them are actually beyond the fear of radiotherapy. This is something I would like to definitely stress here.
Right. So coming to the post-mastectomy radiotherapy, as Dr. Anushil already mentioned in his talk, and we are all quite aware that the clear-cut indications for post-mastectomy RT like T3 and above lesions, node positive, LABC, post-neoadjuvant therapy, irrespective of response. So these are anyways the indications for post-mastectomy RT. But Jayalakshmi ma'am, coming to high-risk features for adjuvant RT in non-node positive or early breast cancers, can you just
So
detail
in
it?
early breast cancers, central medial tumors or tumors more than 2 centimeters, and with at least one of the following, now most of the, you've got NCCN, which clearly then gives you the clinical prognostic data as well as pathological prognostic data. So it's important to go through that also to see what is the grade. So any grade 3 tumors, if there is any addition of this grade 3 tumors, LVI positivity, ER negative, hormonal negative, these are all high risk features where we would consider. Anything more than 1 node positivity, yes, they would be considered for radiotherapy. These are high risk features.
So previously it was 4 nodes and now it is any
now
node positive is a
yes.
high risk feature and patient should go for a PMRT. I hope the point is well taken.
Yeah.
Coming to a challenging situation, first I would ask Dr. Anushri. In fact, you must be having patients with mastectomy and sentinel lymph node biopsy, which is negative on frozen section. And have you first encountered any such situation wherein the frozen is negative and the paraffin section turns out to be positive either for a single or double micromet or a single macromet?
Not recently in my experience, but we know that frozen section is not as accurate as the final histopathology. It's only 75%. So there are surprises on final histopathology. And now we have trials for where they have seen that with micro metastasis or even in patients who have limited axillary beds. So a case can be made for observation.
So what would be your take if your patient had one of these situations, say a single macromet that turns out on a final paraffin section? What would be your counsel to the patient?
So for a single micromet, I could explain and give the evidence of CSG trial that we don't need to completely clear the axilla.
And for a single macromet?
Macromet, unfortunately, that Z11 trial did not have mastectomy patients, but I think the other trials, the IBCSG and AMROS, they have had patients with where mastectomy was done and limited nodal disease was there. So if they fit into this criteria, then up to 2 we can observe.
So, Sarupa ma'am, so coming to whether axillary RT versus axillary lymph node dissection in an undissected axilla, which is negative on sentinel lymph node biopsy and turns out to be positive. So, what would be your counseling to such a patient? Or what would be your take on that?
So this is a field where we have the answers and also we don't have the answers. So we have the answers from these trials that in place of axillary, if the single lymph node is sentinel lymph node is positive, then you may not go for axillary dissection. We can give axillary radiation that is good enough. But at the same time, with mastectomy, how much do we radiate? Which are the patients we radiate? So that is still a debate. And I think it has to be individualized every time. There is also something that whether a neoadjuvant chemotherapy had been given or not. Right now, I'm assuming that these are the patients where neoadjuvant was not given.
Was not given.
So So if axillary sentinel lymph node biopsy is done, and rest of suppose it is T2 and there are not many high-risk features, then probably we may not opt for lymph node dissection, and we may go for axillary radiation. But like I said, it has to be very, very sure. And whether there has been how many sentinel lymph nodes have been taken out, that is also important.
Yeah.
Dr. Indu, your comments on this? Do we have Dr. Indu with us?
Okay, so I'll say that we have come across situations where frozen was negative and sentinel nodes were negative, and in the final histopath they came out to be positive and axillary lymph node dissection was not done. So I think these, so if it's a patient with a PCS, then we definitely know that patient has to get radiation, and even if micromet comes positive, then you will not go for any axillary lymph node dissection because patient has to get radiation anyways. Now, in mastectomy situation also, if suppose this is a de novo mastectomy, no neoadjuvant chemotherapy given, but if this is the only indication for radiation, I mean, I think we have to understand all those parameters. So we have to take the patient as a whole and understand what is it? Is it a triple negative disease? What are the other risk features of disease recurrence? Is sentinel lymph node dissection enough? I mean, adequate sentinel lymph nodes have been examined, and it's a dual tracer. If it's a single tracer and only 1 or 2 sentinel lymph nodes have been dissected, then we have to, then I would like to offer radiation. But if it's a proper sentinel lymph node dissection, dual tracer, proper axillary lymph node has been, axillary lymph node dissection has been done, it's a good axillary lymph node dissection, then I will not like to treat axilla, because we don't want to add on to lymphedema, which otherwise also patient will have because of sentinel lymph node dissection. So, and of course, it also depends on whether neoadjuvant chemotherapy was offered to the patient, whether axillary lymph nodes were positive radiologically or clinically. And if they were radiologically negative and ultrasound axilla was done, FNAC from the axilla was done to rule out that there were no axillary lymph nodes at that time. So I think we have to take all these factors into account before finally saying no or yes for offering axillary radiation for these patients. Because otherwise also post-mastectomy, we offer axillary radiation only in a heavy nodal burden or where the lymph node ratio in the lymph nodes which have been removed, it's high. Like a patient with 6 lymph nodes dissected, 4 are positive, versus 28 lymph nodes dissected, 2 are positive. So we have to take into all those parameters also into account while deciding for axillary lymph node dissection.
Dr.
Radiation.
Chirag, here I would also ask you people, because certain St. Gallens and certain other studies, when they say more than 2 sentinel lymph nodes positive, you do an axillary dissection, right?
Yes,
so if it is something like that, then naturally the question here doesn't arise, if there is more. And what is the minimum that you do? Many studies are talking about a minimum of 3. So has a complete sentinel lymph node, biopsy has been, is it commensurate? We'll need to see. So what is it that you people also take? I would like to know. Is it minimum of 3? And
Yes, ma'am. As a practice,
Yeah.
we consider 3 as the threshold. Now, we need at least 3 nodes to call it a complete sentinel lymph node biopsy, at least in our practice. Yes.
Can I just chip
Yeah.
in
Yes, sir.
here?
Yes, sir. Yes, sir.
So basically, when it comes to sentinel node, the number of nodes, a patient who is having upfront surgery versus a patient who is being treated after neoadjuvant are considered in 2 separate categories. So for patients who are having upfront surgery, if you are satisfied with, say, the sentinel node identified in terms of, say, it being a reasonable size, it being sort of either the blue dye or the radioactivity is properly localized to the node, and after removal of the node in the rest of the axillary there is no residual radioactivity, then even a single node or 2 nodes may be considered sufficient. So this is for a patient who's having primary surgery. Now for a patient who's having surgery after neoadjuvant chemotherapy, one that sentinel node, there is still a lot of debate whether it should become a standard of care or not. But whatever centers practice it, it has been found that if you have 3 nodes at least in the specimen, then the false negative rate is below 10%. So it is recommended that for patients who are having NACT, you should get at least 3 nodes. So that is why a dual tracer is mandatory if you're doing it after neoadjuvant. And some people also recommend what is called as a targeted axillary dissection, where removal of the node which was positive, and you sort of put a marker on the node, you localize that node. But that is again a lot of controversy, but post NACT 3 nodes are required.
Also, a combination of maybe targeted node plus a sentinel node in post-NACT patients.
Dr. Chirag, I want to make a quick
Yeah.
comment there.
Sure.
So I want to just reiterate that all these trials of de-escalation, they had, for example, Z11, they did not have patients who had NACT or mastectomy patients or patients who were going to get partial breast irradiation. And with respect to post-neoadjuvant sentinel lymph node, I completely agree with sir that 3, and you need to really validate and prove the accuracy of what you are using, dual dye, or in your hands, what is the false negative rate before making it a practice.
Yeah,
Dr.
so yes, radiation therapy as well as reconstruction, they have proven to be beneficial when they are used separately. But whenever they are used combined, there are certain issues. So I would like to start with Dr. Anushri. Dr. Anushri, do you assess the need of PMRT in a patient before you go ahead with surgery, and the patient has been planned for reconstruction? And does the need of PMRT, indication of PMRT, it impact your decision making for the type of reconstruction or the timing of reconstruction?
Yes, yeah. So it's one of the scenarios where we need to discuss the treatment plan with radiation oncology. So if there is any potential of getting PMRT, it definitely affects the reconstruction choice. So we know that PMRT negatively affects, be it autologous reconstruction or implant-based reconstruction. And in armed forces, we have tried a sort of immediate delayed kind of an approach where we had put in expander and then we later on exchange the expander with the implant post RT. But there are a lot of things. So if I know that the patient is not going to get PMRT, then my choice would be an immediate sort of reconstruction, and then the choice of autologous versus, we know that the long-term outcomes of autologous are better, the complication rates and everything, but the choice is really depends on the shared decision making between the patient and the surgeon. And not everybody is suitable for autologous reconstruction, and there are some constraints also, like you should have a microvascular surgeon available, or you should be well versed with extended LD flaps. Definitely. So this is a scenario which needs to be discussed beforehand.
So, Dr. Jayalakshmi, ma'am, what is your clinical experience regarding irradiating the reconstruction patients? So in terms of tumor control as well as toxicity.
I must be candid in saying that most of the patients at whom we are getting are not, we know there is no tissue expanders being used. Most of them are autologous, okay? And there may be immediate reconstructions, but as long as the wound is healed well, we do not have much of a problem, with radiation after that. There have not been much of late, very few patients, particularly if it is, upper outer quadrant and, in those areas, sometimes we have the, scar giving away very rarely, and particularly if it is going to be hypofractionated. So I do have a look at those things, and rarely those type of patients, I may go in for a conventional fractionation if I feel that the scar is a little, it may give away or there has been a delayed healing. But otherwise, because most of them are autologous, we do not have much of a problem. Very rare to find tissue expanders being used here.
So you are comfortable with immediate autologous, and the toxicity rate is not very high. I would also, yes, ma'am. I would also like to get the inputs from Dr. Swarupa and Dr. Indu Bansal. Ma'am, what is your clinical experience?
So, for me, I would be more, if we look at it theoretically, yes, we have seen many of implants, radiation post-implant, there may be cosmetically, they may not be as good. There may be capsular contractions, there may be ruptures. So these have been seen. So autologous reconstruction, I would be more comfortable with them, and I would probably give a much better outcome. But I myself, I do not have much experience with implant-based radiation therapy. We have been more comfortable with autologous reconstruction followed by radiation. So I think theoretically, I think they are better cosmetically as far as my experience is concerned.
So earlier there were studies that said that autologous reconstruction, they fare very poorly to PMRT. Yes. But yes, now of late, many studies are there that they are saying that the patients, they tolerate autologous well.
Yes, and we have seen them in our practice. Yeah. And we have taken photographic pictures and they have done excellent. Many times it is very difficult to even understand which side has been treated and which side has been radiated. So they have excellent results these days. Probably the ones we read in literature is probably because the radiation technique was not as good.
Yeah, exactly.
So nowadays we have very good techniques. The skin is spared and the fibrosis is much less. So I think cosmetically it is beautiful these days.
And what fractionation do you use in such patients?
Yeah, so hypofractionation we have started using. I have been using hypofractionation since the past 3 years, even for autologous reconstructed breast. Until now, I have not seen any kind of fibrosis or contracture or change in shape. And now we have the guidelines as well that we might go ahead with hypofractionation in autologous breast reconstruction. Without any boost, of course. So nowadays we don't have any for boost. We are not giving, but yes, we are going ahead with hypofractionation as well.
Do you face any challenges when targeting IMC? So suppose internal memory coverage is also to be given. So in reconstructed breast.
Yes, it is. It is not only for country, but even for the dose we receive. So many times, for a lot of lung is radiated in that case. So even now we are having challenges with such patients. So for even right side breast also, we have seen a deep inspiration breath hold technique has helped a lot where we have treating the reconstructed breast. Actually, now I have a patient who have a reconstructed breast. We are treating the internal mammary, the supraclavicular. And initially, we were doing without DIBH, and there was about 940 cc of the lung. And with the DIBH, we have a 1600 cc volume of the lung. So the lung has been spared. So yes, we have to devise in a new ways. And I think as radiation is a lot of art along with science. So we have to use those. So
great input, ma'am. Yeah. Dr. Indu Bansal, ma'am, your opinion?
So I would also say that, I mean, we used to see few cases with implant few years back, but I think now more with our surgeons doing excellent job and the plastic reconstructions being done so beautifully that we are coming up with real amazing surgeries in a reconstructed breast, where in fact sometimes even the reconstructed breast looks better than the original breast. Or the opposite side breast. And with autologous reconstructions, the toxicity, I would not say it's more, but actually, if you say hypofractionation is a cautionary recommendation, it's not definitely recommended for hypofractionation, but of course, more and more data is there, and all of us are doing hypofractionation even in reconstructed breast. But I think the problem that I face is in very bulky patients. Sometimes when the lateral separation is more than 25 centimeters. So in those cases, repositioning them and reproducibility of such patients is really tough. So sometimes, I mean, we do make masks or we use Vaclox, and we tried a lot of things in very bulky breast while putting a tape and all, but so bulky breast, I'm little, it becomes bulky breast with reconstructions and oncoplasty where everything has changed. In those cases, delineation is definitely tough. And in those cases, you see more of, skin reactions in the inframammary fold and in the supraclavicular area, not elsewhere, but in those areas, you specifically see some skin reactions coming up. But these days, we have very good radiation protected creams, which are really giving good cosmetic results. Now, the fibrosis is also not that much, not that very high. But of course, when we are doing IMC, and Sarupa also said that although for DIBH, we mainly use it for left-sided breast, but specifically if you are doing IMC, then I think DIBH helps. And one interesting thing that I came across was that we have been focusing on lung dose and heart dose for a left-sided breast. But I did analysis of few patients. I don't have any experience of DIBH, but right-sided breast patients, we have hardly only 1 or 2. But in these cases also, if you see, the liver dose is also half, although the liver dose is very minimal. But if you ever see your DVH, so liver protection also you achieve if you do DIBH on the right-sided breast, and of course the coronary doses and the lung, it's not very substantial, but what I noticed was that if you are getting, say, 8 gray in a DIBH, in a non-DIBH plan to the liver, the D mean, then it comes down to 5 or 4, which was something very interesting. I never noticed, I never paid any attention to that. But that is one additional point which I want to make here. Although we are not offering DIBH to our right-sided breast patients, but in 1 or 2 that we did, this was an additional advantage. So if specifically patient had received any liver toxic chemotherapy, or the patient has some CLD or any such elements, sometimes you come across patients who have CLD, then maybe DIBH might be of help in reducing your liver doses also. This is my additional input that I would like to put here. So implant contracture, I have seen in one case which we treated few, but now that we have guidelines for implant-based radiation and reconstruction-based, so since we have started using those guidelines, I think we have been able to do a better job with radiation also, even in reconstructed or implant-based patients.
And what should be the approach in contralateral prophylactic mastectomy? So where is bilateral reconstruction cases? So what should be the approach?
So approach in terms of what? I didn't get the question right.
Radiation planning. Suppose there is a patient of bilateral reconstruction and the opposite breast has been removed because of the genetic mutation and all. So patient opted for bilateral mastectomy followed by one-sided radiation planning.
Okay. So I think whenever you are planning your bilateral breast for radiation, so there are 2 different scenarios. One is where you have to treat bilaterally, and one is where patient has underwent a reconstruction but is getting radiation to one side. So I think these 2 would be completely different scenarios. So if it's a unilateral radiation where reconstruction has been done for the opposite side, then I think your planning would remain the same, but you will just ensure that your extra dose is not going to the contralateral breast. But if it's a bilateral breast, then apart from the hard doses and apart from your SCF doses, you have to be very careful about the overlap areas in the middle part of the breast where there can be some necrosis if you are not very careful. And so you have to be very careful. And I in such situations, we daily do imaging. I mean, I don't treat bilateral breast without a IGRT. It has to be a daily. I mean, my doctor is there. So we don't leave it only on the technologist. In such cases, you have to be really careful about the overlap areas in the middle part. So these are special situations where and sometimes a patient comes to you where patient has received radiation to one side, and now the patient develops a recurrence of the contralateral breast, and then they get radiation. So then you have to take the DVH and take the radiation plan from the previous center if the patient has not been treated at your center, and you need to know the hard doses and the contralateral lung doses, and also then you have to really do a lot of hard work, understand the previous treatment plan, and it's always better to get the DVH from the previous center. You cannot treat such cases without having the radiation details from the previous center.
Exactly. Yes, ma'am. So, Dr. Anushri, you were talking about the delayed immediate type of reconstruction. So, what do you think is the ideal time for, putting the implant, replacing the expander with the implant? So, in most of the cases, it is done after radiation, but there are a few studies which say that it can be done before radiation also.
You're right, Dr. Prikshi. So there are a few studies from the Maurizio Nava group from Italy and Cordero et al. So they have actually said that radiating the implant is better than radiating the expander, and they had recommended that we exchange before RT. In my previous institute, we used to exchange post-RT. So it can be somewhere between 6 months to 1 year, and it needs to be individualized. I would urge everybody in the audience to actually read this. There is an Oncoplastic Breast Consortium, and they had issued a consensus paper on this implant and PMRT. Very interesting paper. And I would just circle back to one point made by Dr. Anushil, that he said that subpectoral implant is the trend, but on the contrary, now there is some evidence. There is paper by Cicerio Urban that doing pre-pec implant reconstruction, even without using ADMs, and their post-radiation outcomes were also acceptable. And generally, less than 10% implant loss rate is what was acceptable, to this consortium. And with oncoplasty, one important thing is that how the implant is covered with respect to post-RT complications. And now with oncoplasty, we have other options, alternatives to ADMs, which is utilizing perforator flaps, making into lower pole slings. So I think we are making with these advancements, I would say that immediate implant-based reconstruction is not really a contraindication, but you need to see that what works in your hands, and probably we need to audit our results with our radiation oncology colleagues, that how have our implant series done over short term and long term.
Right. So it was about the mastectomy reconstruction. Now we know that breast conservation therapy is the standard of care for majority of the breast cancer patients. And an important part is whole breast irradiation along with a cavity boost. So an extra dose to the tumor bed is important. And we have already seen, it was mentioned by Dr. Anushil also, the indications of cavity boost. So what are the methods which you follow, Dr. Jayalakshmi ma'am? So what are the methods and for cavity boost delineation?
The commonest that we are using is only electron boost, okay, because it delivers sufficient dose to the cavity. Most up to about 3 to 4 centimeters is not much of a problem. But for very deep-seated lesions which are just near the pectoralis and the cavity rather, if it is that way, then it would be a EBRT boost. So we do compare. Most of the patients nowadays have a PET-CT, and we have fusion capabilities in our planning systems. So when we are planning the whole breast RT itself, we check whether it is the same area, and surgeons are nice to give us the clips there also. We are using that. Of course, whether are oncoplastic procedures, there are problems. We do involve them with them. But I'm talking about the majority. So using the clips, and that it is that same area. And I would still say one of the simplest methods is asking the patient also where exactly it was. Okay, that really helps because they are in 95% of the time they're able to, and many a time the scar as well as the delineation becomes much easier for an electron boost for them. And for the ones which are deep-seated, we use external RT based boost.
Photon based, yes.
Yeah, photon based boost.
Indu ma'am, are you also using your mute? Yeah. Are you also using electron boost or photon?
No, so I would say, cavity localization is actually a problem many times because I think what is very, very important is if we have a pre-operative diagrams, which we rarely find these cases because we're entering the data into the computer because of HIS. But so usually a pre-operative clinical diagram, clinical history, operative notes, mammography findings, PET scan findings, CT if done before, all those are very, very important in understanding about the cavity. And apart from that, what I also do is get an ultrasound guided localization at the time of boost planning. So what I normally do in my practice is that at the day of simulation, before we take the patient for simulation, I send the patient to ultrasound room for an ultrasound guided cavity localization where they put the markers, and my doctor is there at the time of marking the tumor so that they can tell about the exact history, because radiologists are in a hurry. So it's always better that a doctor who would be there in simulation, that is usually present at the time of cavity localization. So because sometimes the scar may not correlate exactly with your preoperative tumor. Sometimes the scar is completely away from the pre-op tumor. So, and of course, after oncoplasty, definitely it becomes very difficult. So the intraoperative clips, the pre-operative history, detailed notes, clinical diagrams, patients' history, CT, PET, MRI, fusion, PET fusion, all those things help. And what I've realized is that even if you have to do a sequential boost, if you give the boost plan at the time of simulation, when you start your pre-boost plan, then the dose spillover is lesser, rather than planning a boost after delivering your 15 days of treatment and then planning a boost. So if you are doing with photon-based treatment, then I usually plan the boost also at the time of first fraction, even if it's a sequential boost, or whether it's a sequential boost or a SIP in both the cases. So then we are able to localize or restrict the low dose spill in the rest of the breast, leading to good cosmetic outcomes. Now coming to whether I use photons or electrons, as I said, it depends. If it's a very thin, if finding the cavity is difficult or it's a thin breast, it's not a deep-seated tumor, then electron boost also helps. But usually I'm doing, it's an individualized plans. For some patients, I use a photon boost. For some patients, I use an electron boost. Now, cavity localization, I think there is a scoring system, which is CVS, Cavity Visualization Score. So 0 is when you can't find any cavity, and 5 is when a very smooth cavity is being localized, which usually happens after a seroma. So if it's a CVS 5, then it makes your job a lot easier. But if it's a CVS 0, then marking the cavity is actually a lot of hard work. So everything actually helps. All the pre-operative details are very, very important. So clips are definitely a lot of if clips are there, then it makes a lot of work easier for us.
Yes, right now, ma'am, clips are, I think, the most important point which needs to be taken care of. And it also, I think it also depends upon the sequence of surgery and chemotherapy and radiation therapy. A patient receiving neoadjuvant chemotherapy followed by surgery, in such a patient, cavity will be localized in a much better way as compared to a patient who completes 4 months or 5 months of chemotherapy before coming to the radiation department.
So I think that was the reason that I said pre-treatment, pre-chemotherapy marker placement and clip placement.
Yes.
They are very, very crucial because nowadays with good chemotherapy drugs and immunotherapy being used, we are seeing so many patients who are complete responders, and you are not able to localize the cavity also in such patients because there's a long time gap between surgery and chemotherapy. So cavity becomes smaller.
Collapsed, yeah.
Collapse. So
Yeah.
it leads to a lot of problems.
And there might be migration of clips in such a long time. Yeah.
So that's why minimum of 4 clips, 4 and 1 clip at the base is also very important. Sometimes you get just medial lateral clips, but there is no clip at the base. So at least 4 to 5 clips is what is actually needed. We request our surgeons and medical oncologists to please get the clips placed before neoadjuvant chemo.
Yeah,
And many times
I'd like to add,
yes, ma'am.
Dr. Prexy, I'd like to add
Yes.
that we have to go back to a previous training. The person, the doctor who sees the patient in the beginning should make it a point to draw a diagram. Just like in cervix, we still draw the diagrams.
Yes.
So for breast also, it is very, very important to have the diagram exactly in all, from all directions, in all, so we should have that diagram. That helps a lot for us. And the diagram should be named, should be labeled as well.
So for partial breast or accelerated partial breast, yes, the cavity localization part is same. And it is even more important in both these scenarios because in cavity boost, at least we are giving whole breast irradiation.
Yeah.
But in partial breast irradiation, only the cavity along with safety margins is being irradiated. So a small geographical miss might lead to a recurrence. So for partial breast irradiation, which patient do you consider and what techniques do you prefer, Dr. Swarupa ma'am?
So partial breast and accelerated partial breast radiation, we still have, although the indications have developed, they are not as before, but yes, we have to be very sure about which are the patients we are taking. So they should be the ASTRO guidelines. The low risk patients we should take for the partial breast irradiations, and the techniques. It is the external beam radiation, but also we have done a few patients earlier with brachytherapy also. So we have studies regarding with brachytherapy which can be done during the surgery. So the needles can be placed during the surgery in the cavity. So in that way, it has the advantage that you can see the breast cavity, the boost cavity, the tumor cavity right in front of you. And it is not going to change the size of the shape. So you can put the needles at that time. I think till now, I think that is still, I consider, the best way of doing a partial breast irradiation. And that is how we do whenever we choose a patient for partial breast irradiation. Up to the EBRT is also done, 3D CRT, IMRT, they can also be done.
Yes, ma'am. So any experience about intracavitary radiation like Mamocyte or SAVI?
I have done personally, Mamocyte SAVI I have not done, but we had published a paper also with implants. So this was when I was in Artemis itself, we had published that the same with which we call partial breast irradiation now. So we had done it, the needles we had placed as a boost. So we placed the boost first, followed by the external radiation. So yes, we have done some interstitial brachytherapy, but not Mamocyte. I haven't done Mamocyte.
Indu ma'am?
So I think accelerated partial breast irradiation is now coming in a big way. Now that we are reducing the volumes, we are reducing the fractions. So accelerated partial breast radiation has been tried with 3D CRT, with IMRT, with interstitial brachytherapy. And something very interesting which is coming up is SBRT breast. So what I think the trials have been that 3D CRT definitely leads to poor results. It is not recommended because cosmetic outcomes are poor. With IMRT, accelerated partial breast radiation, definitely the trials are showing good results, specifically fast trial and fast forward trial. Now, some people are doing ultra hyperfractionated treatments also, like there is something which is known as overnight radiation, where they give just 4 fractions, 2 fractions, 1 in the morning, 1 in the evening, and 2 next day, and the treatment is done. Now, pre-operative single fraction breast radiation is also being investigated in a number of countries, where they give a single shot of 20 gray pre-op. But of course, for accelerated partial breast radiation, all of these criteria must be met. Like, it should be invasive ductal carcinoma, not recommended for invasive lobular or for other histologies. Tumor size should preferably be less than 2 centimeter or less than 3 centimeter only. Some people are doing it in even N0, N1. Earlier, it was being done only for N0. Margin should be less than more than 2 millimeter. For DCIS, it should be less than 2.5 millimeter. It should be no chemotherapy the patient should have received before. These are some of the indications for accelerated partial breast radiation. So, in fact, in some countries, specifically in University of Maryland, there is a special machine which is called as Gamma Pod. It's a SBRT tool. This is a machine which is used only for SBRT breast. So what they do is the patient is treated in a prone position, and there is a specific cup where the breast fits in. There are different cup sizes. Patient lies down on a machine, but then it goes 360 degree, and the patient goes prone. From a standing position, the patient goes to a prone position, where they are giving such sorts of treatments, and with very encouraging results. In fact, some trials are going on where they'll give only pre-operative SBRT to the tune of, say, 20 gray single session or 30 gray in 5 fractions. And people are keeping the patients under observation and doing BCS or delayed surgery even after 6 months to see for complete pathological response. So I think a lot of exciting work is being done in the era of accelerated partial breast radiation, and now it is being accepted. So pre-operative with no surgery, I don't know whether the surgeons will be out of job or what will happen, but it is a very exciting thing to keep our eyes on. So honestly, I don't have any experience of a mammocyte myself. I have done few cases of interstitial, but I saw 2 cases of mammocyte and Survey applicator when I'd gone for some training in MD Anderson. But I have personal no experience. So there is some interesting tool which I am forgetting the name, something called as Zorbug or something. It's for cavity localization, which is being used in certain places for accelerated partial breast radiation, where they're giving very high dose of treatments. So fast forward has showing some very good results, 26 gray in 5 fractions. And it has been found to be as good as 40 gray in 15 fractions. So of course, but it's for very selected few patients, we have to choose the patient really, really well if we have to offer such treatments.
So Biosorb, I think you're talking about Biosorb cavity localizer.
Biosorb. Yes. I was forgetting the name. Zorba. That was.
So there are so many things going on right now. You're correct, ma'am. So I got along with the term very accelerated partial breast irradiation.
Yes.
VAPBI. So they are completing in 4 fractions, and single, even for elderly patients, even in single fraction, they are giving 20-21 gray. And
yeah.
But Prekshi, there is an important thing that, where we should not consider also. Like
yes, ma'am.
If it is a lobular tumors, if it is LVI positive, women less than 40 years of age, hereditary breast cancers. Here, I mean, it's important, even if the other indications look like they fit here, we do not consider it at all. And this has been, I think, St. Gallen's has come out with it saying that, these are areas where we do not consider also.
Yeah, BRCA negative, definitely.
Yeah.
Even the size is important, because size is more than
3 or less than
do not give.
Yeah.
So
it's not only neoadjuvant.
I also think that Yes, ma'am.
I was saying ki no chemotherapy before. So it has to be very strict criteria.
Yeah.
You have to follow all those. Yeah.
Absolutely.
Dr. Chirag?
Ma'am. So we were talking a lot about cavity localization and how oncoplasty surgery, there is a lot of parenchymal rearrangement, and we have spoken at length right now about what are the reliable guides for deciding the cavity and for the boost. I would like to ask the radiation oncologist panel, how many clips do you prefer and where do you want the clips to be placed in a post BCS cavity? How many clips are ideal? And where all do you like them to be placed? Dr. Sarupa, ma'am. Am I audible?
Yeah, you are.
There might be network problem with ma'am.
Okay. Dr. Indu, ma'am, would you like to take the question? So how
So
many clips do you
I think
ideally like?
ideal recommendation is to put 6 clips, anterior, posterior, medial, lateral, 1 at the base and 1 in the mid of the cavity. That is actually ideal, but minimum 3 clips at least, 1 at the base and 2 at the sides at least, because sometimes the clips may migrate. So ideally, if you put at least 4 clips, then even if 3 remain, then we will be able to localize the cavity. But ideal recommendation is 6.
So, Dr. Anushri, what is your routine practice while you're placing clips?
So what the evidence recommends is 5. We usually put 5, and we put it at the tumor base. If it's a limited volume displacement, then it's not an issue. But if it's like a mammoplasty, then the clip migration is also there.
Right. So coming to the next challenging situation that sometimes can arise, Dr. Indu Bansal, ma'am, what do you do when the surgeon has forgotten to put the clips, or the clips have been missed somehow? Would be due to a tumor that was removed, just a lumpectomy was done with adequate.
I think I would say that in most of the academic centers, clip are being put, but we do come across a good number of patients who don't have clips, even in academic centers. So I would not say that it has become a routine. So of course, as I said, you can't start contouring without going through each and every report of the patient. After you have to read the history yourself. You can't rely only on your resident doing it. You have to really ask the patient, where did she feel the lump as per the history, because sometimes even in the PET report, if you see the PET report, many patients don't come with a mammogram, they come with the PET report directly these days. So sometimes because of the arm position or something, the tumor may not be exactly in the same position where it is mentioned. So sometimes we find a lot of discrepancy in the reports where it might say that it was in the upper outer quadrant, but actually the tumor is in some other quadrant, or it's in the upper medial quadrant. So you have to go through each and everything. As I said, the pre-op diagram definitely helps. Pre-op history, initial mammogram, PET-CT report, MRI report. And of course, you have to, as I said, that I also get an ultrasound guided cavity localization. And of course, you have to talk to your surgeon. If you are in doubt, you have to call up the surgeon and find out what were their operative findings at the time of treatment. So we do come across these situations, but most of the times, if we are not able to localize the cavity completely, then of course, you give an extra margin, which is not very good cosmetically for the patient. Right. So, but you don't want to miss the tumor, so you end up actually treating extra. This is what yeah.
So as they say that either you forget the boost or you forget oncoplasty. So if a patient has indication for giving tumor bed boost, then displacement, these procedures including major displacement or replacement techniques should be avoided. Such oncoplastic procedure should be avoided, or if a major oncoplastic procedure has been done, then we have to omit the boost in such patients.
So I think sometimes what we come across is that we have to understand, is it a volume replacement
or displacement?
Is it a volume replacement, or is it volume enhancement? I mean, any of these things happen. So reading the clinical history, talking to your surgeon, I think that's the most important thing that helps us in such situations. And in fact, calling them to your planning room.
Yeah, that is very important.
And offering them a cup of coffee.
I just want to make a quick point that in all the training institutes and during the oncoplasty training workshops and fellowships, I've seen that we continuously keep reiterating we need to put clips, we need to make clinical diagrams. I think it helps if you take your radiologist also in confidence and a radiation oncologist also, and develop a uniform sort of lexicon where you also not only you mention the quadrant, but distance from skin, distance from NAC. So all those things will help in the long run. Practically, I agree with all of them that it's not universally followed. And the other problem is that sometimes we also get patients who are first seen by medical oncologists, and if they are clinically examined, then I mean, there may not be a clinical diagram. Then it's really, especially we still see patients who miss out on breast conservation because they had aggressive tumors which are sort of disappeared with neoadjuvant chemotherapy, and there was no clip placement.
So actually, it has to be me who has to say that we are running out of time and I have to continue further also. Yes, earlier conventionally it was 5 weeks, then moderate hypofractionation 3 weeks. It is being practically practiced in most of the centers globally as well as nationally. And now these next generation ultra hypofractionated trials, they represent another group, and it has further shrunken to 1 week. So, ma'am, just a quick word about whether do you follow conventional fractionation in any of your patient? What is the indication for the same?
So
Dr. Jayalakshmi, ma'am?
I must say that almost 95 to 98% I've switched over to, hypofractionation, not ultra hypofractionation. Okay, ultra hypo, I think it's going to take time for us to sort of get used to even that idea. And even if you look at the trials also, fast forward and other trials, they were all designed to look at IBTR. What is, we still do not have the long-term toxicities in ultra hypofractionation. So whether we can straight away take that, it's going to take some time. Whereas most of the time I am using hypofractionation only. But yes, there are certain patients in hypofractionation. What I have seen as I have switched over in the past about 2 to 3 years is that I'm talking about the local reactions only. They are delayed, okay? In the same set of patients, most of them are receiving chemotherapy and then they're coming in. So most of the time they are going ahead and completing the radiotherapy. There is no problem at that particular point of time. They go home and after 1 week, they come back with reactions. This is what we are seeing now. So if there has been a patient like, for example, with, comorbidities, diabetic, who has had a delayed wound healing, big breasts, okay, in these sort of patients, I may consider conventional fractionation. But otherwise, in most of them, as I told you, about 95 to 98%, I'm able to go ahead with a hypofractionated schedule, which is about 40 gray 16 fractions. But I still have not gone on to a simultaneous boost. I only go on to a sequential boost. Yeah.
Yes, ma'am. So, Rupa, ma'am?
Yeah, so for me also, we are doing most of the time, I'm doing hypofractionated with simultaneous integrated boost. Most of the time, the boost cavity is localizable. And in very selected patients, we are going ahead with the fast forward trial that is in 1 week of 25 grays and 5 fraction. But this is for very, very selected patients, very low risk patients where we do not need to radiate the axilla or to address the axilla. Conventional fractionations, just like Dr. Jaya said, in very selected patients who have, we are not very comfortable with the lung dose and the because of the conformity, because of the shape of the chest, and then in that cases we are using conventional, but very rarely. Most of the time it is hypofractionated with SIB and ultra fractionated in some of the patients with very low risks.
For bilateral, you are using moderate hypofractionation simultaneously? bilateral breast
yeah.
cancer?
Yes, I have not. We just had one bilateral, but I treated with conventional fractionation. I
Yeah,
have,
we also treat actually with conventional.
yes.
Indu ma'am, 1 week, which patients?
So honestly, I don't have any experience of accelerated partial breast radiation. I've not treated even a single case. Regarding 5 weeks, so I would say that sometime back, few years back, I was reluctant to switch over to hypofractionation because maybe probably I was not doing my job well because the skin dose was high and patients would come back after a week with a skin toxicity. So I was really afraid to give hypofractionation. But now that we know that the skin doses should be, so now that we are able to manage the skin doses and we are getting very good plans. So I'm finding absolutely no problem with hypofractionation. So as I said, if the lateral separation would be more than 25 centimeters, then maybe in such situations, or if it's a delayed wound healing, of course, then I would go for conventional. But in majority of the cases, of course, I think in 95-97% of the cases, we are going with hypofractionation only. Now, coming to 1 week, as I told before also, that for accelerated partial breast radiation, the patient has to fit into all the criteria. It has to be invasive, invasive ductal, not invasive lobular, it is not recommended. BRCA, it's not recommended. Tumor size preferably less than 3 centimeter. Ideal is less than 2 centimeter. Skin separation should be more than 2 millimeter, and then margins should be more than 2 millimeter. Then, as I said, N0, no chemotherapy received before, preferably hormone positive, more than 50 years of age. Although some people have treated even patients with 45 years of age, but best is more than 50 years of age. Then DCIS less than 2.5 centimeter, low grade, intermediate. Even for intermediate grade, there is some dicey situation. Hyperfractionation is for bilateral breast. It is not yet recommended, so I'm not doing it for bilateral breast. And as I said, I think these are the situations. So for a very elderly, if a suitable patient comes, I might go for 26 and 5 sort of a regime, but I've not done it.
Yeah, and soft
There is a
indication.
small thing which I wanted to interject. When you look at the fast forward trial, there's one more thing which, like, now we are all switching over to hypofractionation with a lot of ease, and then going on to maybe a simultaneous or a sequential boost. But the most important part, when you look at the data of fast forward trials, only 342 of almost 1,000 patients or so received a boost. So are we going to just take that data and straight away use it here? We'll have to, think over and then move forward. That is my take on that. Yeah.
Exactly. So boost, yes, we have covered. Dr.
Dr.
Chirag?
Prikshi, I think we should try to wrap it up. Maybe some quick fire questions. Dr. Jayalakshmi ma'am, your take on regional nodal irradiation, because there are a few questions in the chat box also. So there is a question regarding how do you decide which patient to be treated for internal mammary node, and as combinations that Dr. Anushil was also talking about for regional node irradiation, a combination of internal mammary with supraclav, and can you throw
So
some light on that?
basically, internal mammary, we would sort of consider when there are central or medial quadrant tumors and heavy axillary node involvement, large tumors. So these are the areas. We restrict to the first 3 spaces also. And what I tend to do in hypofractionation is I calculate the BED, and where 40 gray 16 fractions, where it comes to about 50 gray equivalent of a conventional, whereas in internal mammary, because there has not been an involvement, a 45 gray would do there. So accordingly, I give it in the hypofractionation also. That way I'm able to go ahead with it. That is where we look at regional nodal radiation.
Right. So Sarupa ma'am, your take on seroma during RT. So
yeah, seroma. Yes, I think seroma. That's very apt. It is very important for everybody to understand that the seroma cavity has to be included in the radiation field. Before we start the treatment, in our planning scan, we should see if there is seroma. Many times the patient says that we had seroma, but many times we discover it on our planning scan. So the seroma, if it is large, it has to be drained first, and only then the radiation is to be planned. And if a seroma occurs once, it tends to be repeated. So the collection may be repeated. So during the radiation, there has to be very frequent scans or online scans. It should be noted whether the seroma is increasing or not. If the seroma is increasing, it may fall outside the radiation field. So it is always better to get it drained and then replan and restart the treatment.
And any experience with radiation with drain in situ, ma'am?
No, we would always like the radiation, the drain to be removed before radiation starts. No, I haven't seen any patient with treatment in situ drain.
Right, because Dr. Anushil was talking about, placement of a drain.
Yeah.
I
So
thought maybe
we also haven't seen any patient like with whom we have treated. So 10 to 15 years back, nobody was thinking of this 3 weeks treatment, and now it is the standard of care all over the country. So right now we are not comfortable with fast forward and fast trial. Might be 10 to 15 years later, it will be implemented in carefully selected patients. So do you think, ma'am, that we can go ahead with change in the sequence like surgery followed by radiation therapy followed by chemotherapy? So right now the treatment protocol is surgery followed by chemotherapy or NICT followed by surgery. So can we incorporate radiation earlier in the course of treatment if the duration has been reduced to 1 week instead of 5 weeks?
Well, I think this is too early to really talk about that. Initially, when I was doing my MD, we used to give the radiation just after the surgery, followed by the chemotherapy. So I think it is we have to individualize each patient. If the number of radiations are decreased, just like in ultra hypofractionated radiations 5 days. So maybe, so that the chemotherapy is not delayed, we can incorporate the radiation earlier. Just finish the radiation and then start the chemotherapy. But I think it is still a very wishful thought now. We have to have enough evidence and select the correct patients to give the radiation, to start the radiation before the chemotherapy is given.
So, Prekshi,
Yes, ma'am.
can I make a comment here?
Yeah,
I
sure.
think the trials are still not mature for us to give radiation before chemotherapy. But I think I have used the sequence in one patient. So sometimes you come across a patient who is a very early breast, and there is the CAN-ASSIST score has been sent. Patient is not at all willing to start chemotherapy, and she wants to wait for the CAN-ASSIST score to come so that she can calculate her risk of whether she would actually need chemotherapy. So I have had 2 patients where the patient was not at all willing to start chemo. And then the CAN-ASSIST, we were waiting for MammaPrint or Oncotype DX scoring to come. And in that intervening time, it was taking around a month or so. Then I think only in one patient I've done that gave radiation because the report would have taken a lot of time to come. But otherwise, I think not doing it routinely.
Right, Dr. Prekshi, I think we are running out of time.
Yeah,
We
sure.
have
I think
few
we should
things
stop over now.
Maybe we can
I would
plan
like-
a sequel to this webinar maybe the next time. It's overwhelming that we had such an engaging panel, and there are few more topics that are left undiscussed. We'll plan to incorporate them in the coming webinars. Thank you so much to all the panelists. I would like Dr. Rajiv Agrawal, sir, to please share his expert comments and give the vote of thanks.
Thanks for the invite also.
I think we are taking half an hour more than the scheduled time. I think Anushil was too good to say today, because in half an hour time, he spoke so well. What I can say, Gagar mein sagar usne bhar diya. Because the topic was very lengthy, topic was difficult. And for surgeons who are less knowledgeable about radiation, I think he spoke very well. The panel discussion has gone almost 1.5 hours. And today, it was all our panelist was virtually Nari Shakti. and they were too good. And it was a very, very engaging session. Of course, the audience, I was told in between that there were more than 125 audience. So without audience, no seminar is successful. And of course, my young panelist, Prekshi and Chirag, they put the questions very well. So without wasting too much of time, I am really grateful to all of them. Maybe in 4 to 6 weeks' time, we will have another new seminar with a new topic and a very learned faculty. Thanks and good night.
Thank you.
you.
Thank you for
Thank
the
you.
invite
Thank
and
you,
thanks
everyone.
to everyone.
Thank you.
Thank you so much. Thank you. Thank you, Prekshi. Thank